talking about thrombocytopenia and a little bit more of the hospital approach to it, because when you see it in clinic, usually you can just refer them and you don't really have to worry about it. Okay, so here's my little table of contents about things we're going to go through today. So that includes introduction, demographics, how to approach it, history exam, clinical clues. I'm going to go over about 4 different major causes of thrombocytopenia you should always be concerned about, and then kind of skip over the rest of them because there's tons and tons and tons of them, but a lot of times you'll never see them. Go a little bit over the workup and the laboratory evaluation, a little bit of treatment, main takeaways, and then I'll take questions very briefly because I do not want to impede on Jackie's time, because you guys are going to enjoy Jackie's talk a lot more than my talk. All right, so introduction. So why does this topic apply to the internist? And so a lot of it is, you're going to see thrombocytopenia a ton in the hospital, especially with aging patients, especially those with either malignancies, chemotherapies, or on 20 different medications. And so you will see this come up a lot, either as a consultant or as someone working in the hospital, taking care of patients, what have you. Or if you're a proceduralist, this will come up because you always have to check platelets before you do your procedures. We no longer have our HEMONC service, so a lot of you have not experienced thrombocytopenia as much as, say, someone who was on HEMONC and got called with a platelet level of 10,000 30 times in the morning when they're on night flow. And then finally, our facility does cater to these patients still. We're just not taking care of them on our inpatient services. And so these malignancies still come through, hematologic disorders still come through, that, and we have a very, very robust amount of TTP in this area, much more so, than other parts of the region. I have no idea why, but so much so that we actually have a registry. And if you have a patient who ends up with TTP, you're actually supposed to let the HEMONC doctors know so they can add them to the registry, because they've been doing a study on it for several years now. Okay, so moving on. So introduction, thrombocytopenia is defined as a platelet level less than 150,000. That's usually considered the lower limit of normal, but that's kind of a generic term because not everyone who has less than 150,000 is really that ill. So there's degrees of this, and basically go from mild to moderate and severe. Mild, most of us don't really worry about. It's 150,000. Usually it'll fix on its own, and there's really no adjustment in management. Moderate, you start to worry about it a little bit more. There might be some adjustment in management either from your antiplatelet therapies or your antithrombotic therapies. And then finally, you have severe, and that's where you kind of have to start a little bit more of a robust workup. And so despite the wide variation of platelet counts within the population, there's little variation of platelet count in a given individual over time. And so if someone's dropping from 300,000 to 100,000, that is not laboratory value, that is not laboratory deviation. Usually that means that there's something going on. Now, does it mean that they have TTP every time? No, but it does mean that they have some type of biochemical process going on. And so large reductions in platelet count, specifically 50% or more, those are the really most concerning. All right, so how do you break down thrombocytopenia? And so for the most part, how I like to think about it is decreased production, increased destruction from medications, or from other causes. And so if you kind of think about it from those 4 ways, that will kind of usually give you the answer. And so if you're not really destroying them, you're not really building them, those aren't the problems, then usually think meds. And then if it's not meds, then phone a friend, because it's probably something other causes that you're going to have to really go looking for. All right, so here's a little nice demographic or a little picture that I like to think of when I do. So on the top, this is a little bit more of your decreased production. And so this happens in the bone marrow. Typical causes are going to be myelosuppression. So that can come from myelodysplastic syndrome, from alcohol abuse, obviously from chemotherapy and medications like we talked about. Vitamin B12 or folate deficiency will also affect your platelets. Myelofibrosis will do it, all of your malignancies. Infections is a big one, liver disease is a big one, and autoimmune processes obviously will do this as well. There's a bunch of biomedical markers on here. Really, you never really get tested on them in terms of boards, so it's really not high yield to memorize those. It's kind of just important to memorize what are the causes and what are you going to be looking at clinically. Then you have your destruction. And so that can either go through apoptosis, which is going to be destroyed by spleen macrophages and phagocytosis in the liver, just sequestration in the spleen, which obviously happens, endothelial injury, which is what they're supposed to be destroyed from, and then obviously antibody mediated, so that's going to be your ITP and your other processes, which we'll get to in a little bit. And so that includes sepsis, DAC, MAHA, drug-induced ITP, heparin with HIT, transfusion-associated preeclampsia help, and intravascular devices. And so that's going to be where you have antibody-mediated platelet destruction. All right, and so I am not going to go over all of these things because each one of themselves could technically be their own talk, but you have tons of them. And so you have your false thrombocytopenia. So that's going to come from platelet clumping from EDTA. They didn't prep the blood appropriately. It's going to come from clumping from 3A or 2B inhibitors, or they're just going to come from really giant platelets. You have your inherited form, so you have von Willebrand disease, you have all the other ones listed there. You have your true thrombocytopenias. And as you can see, there's a lot of scary ones on there, and those are the kind of things that we like to think about in the hospital. One of the big ones on there, and I think a lot of us tend to kind of overlook, is liver failure. So if you have someone who comes in, thrombocytopenia and cirrhosis, that tends to give you the explanation pretty quickly. And then you have the ones that are kind of a little bit more acute, and so alcohol is a big one. I think a lot of our patients actually come in with that, and so that's a big one. Nutrient deficiency, same thing. Drug-induced, so some of the big drugs you'll see, heparin's obviously a big one. Sulfonamides, quinine, ibuprofen and naproxen. Antibiotics are another big one. And then your anti-seizure medications are going to be big too. Apparently walnuts and herbal teas can do this too. I've never diagnosed someone with thrombocytopenia secondary to walnuts, but it's listed for completeness sake. And then infections. The big ones are going to be EBV, hepatitis, HIV, and then H. pylori are going to be the big ones you think about. All right, so this kind of breaks it down a little bit more concise, and then which ones are really the most important. So I tend to think of this, I think of ITP, TTP, HUS, and DIC are usually, and HIT are the ones I think about that are the most serious when I'm seeing them in the hospital. And then in terms of production problems, sepsis and infections will do this too, but less through a destructive mechanism and more through myelosuppression mechanism. And then obviously you have aplastic anemia, bone marrow failures, malignancies, dehydration, and then inherited forms as well. All right, so demographics. So why does this matter to you when you're on the wards and in the ICU? Well, it actually confers an increased risk of mortality. And so patients with thrombocytopenia when they're admitted to the ICU or to the wards actually have a very strong association with increased mortality when they have thrombocytopenia, independent of overt DIC or anything like that. Now, the number one major cause that's associated with this is obviously going to be sepsis. And so I think somewhere between 40 to 48% on the wards and ICU, sepsis is going to be your main cause causing this. Not even just DIC, it's just going to be sepsis causing myelosuppression. And then obviously medications are going to be a big part of it, which are both non-cytotoxic and cytotoxic. And then that's kind of the big ones that you're going to see, especially in the hospital when they've studied this. All right, so thrombocytopenia and bleeding. And so surgical bleeding is really going to be more of a concern when your platelets drop below 50,000. And so that's generally when someone who's coming into pirate or someone who's coming in overnight and, you know, the dietary wants to operate on their foot tomorrow, you always have to make sure you look at the platelet and be like, all right, are they above 50,000? Are they 60,000? Do I have to transfuse them in the morning? Do I have to prep for this? And so this is kind of, you know, just the routine things you have to think about that are non-serious, but also will affect you in the hospital setting. And then it's always important to think about other factors that will affect platelets, like platelet function. So if they've gotten aspirin recently, if they're uremic, these are going to affect lesser. If they have lower amounts of platelets, this is going to kind of compound that factor. And then the other big thing about aspirin is it affects the platelets for the entirety of their lifestyle. So once you've given someone aspirin, usually it affects all the platelets for the 7-day lifestyle that they have. Now, obviously, not all platelets are going to be there for 7 days, which is why usually people wait for the 4 or 5 days for aspirin to wash out. All right, how to approach this? All right, so the questions to ask. So is this real? So is this just a blood draw error? And so obviously the answer is if you get someone, I mean, we do this all the time with hemoglobins. The same thing applies to the platelet levels. If it's low, just go ahead and repeat it. And then the other question is this new? And so if you get someone who has, comes in with platelet level 35,000, you want to see, okay, what has been their platelet level before? If they normally come in with a platelet level of 300,000, you have serious issues. If they were here a week ago and their platelet level is 45,000, you're probably in the clear, and then you just need to keep a watch on it. And then trend and baseline is important, and then other hematologic abnormalities. So do they have pancytopenia? Do they have a leukocyte count that's skyrocketing? These are the things just kind of think about when you're approaching these problems. All right, these are generic history questions. So previous episodes of low platelets or bleeding, enlarged lymph nodes, previous cancer history. The big one that I've caught people with thrombocytopenia on is they bleed when they brush their teeth. And that's the last time I caught someone who had thrombocytopenia. They had platelets less than 10, and they ended up having non-Hodgkin's lymphoma when we actually brought him into the hospital. They just called us like, hey, we just did some routine blood work. He was here because he had a headache, but his platelets are less than 10. Can you come see him? We did. And we're just like, oh, this is bad. He ended up staying in the hospital for, I want to say, about 3 months until he got chemo and his platelets finally came up. I'll get to his story a little bit later. He's a little bit of an interesting case. All the other stuff is stuff we do anyways: medication history, over-the-counter history, drug history, if they've taken heparin, infections, travel history, diet history, all that fun stuff. Physical exam, the big things are going to be petechiae, purpura, ecchymoses, large collections of blood, things like that. Look for bleeding, especially in the mouth. That's a big one. Here are fun pictures of petechiae and purpura because, you know, none of us can ever remember what a petechial rash is versus a purpura rash, except for Adrian. So it's always nice to have pictures. All right, additional clues to the diagnosis. So big thing for this is looking at the peripheral smear. That is a huge thing when it comes to anemias, thrombocytopenias, and if you can't see it, then just ask the hem-onc fellow overnight, especially if you're concerned for something like schistocytes, because that tends to be an emergency, and that tends to get the hem-onc fellow out of bed overnight and into the hospital, because that's something that's a huge thing not to miss. Big spleen, big liver, all of us kind of know that stuff, lymphadenopathy. I'll skip over that. All right, so I have a fun little case presentation. Let me just check something real quick to make sure I'm not muted up here, because I feel like that's what I'm always worried about. I can't tell. I'm sure someone would have texted me by now. It's technically like hidden. Okay, there we go. Sarwar says we're not muted. Thank you, Sarwar. All right, so case presentation. So a 27-year-old African-American male, no medical history, 3 months of lymph node enlargement, daily fevers, fatigue, and weight loss. In addition, he reported a 20-pound weight loss for 3 months, came into the ED. He had been having gum bleeding, nose bleeds, petechia over his lower extremities. He has this white blood cell count of 12,000, platelets of 337,000 a week ago. He was scheduled for an outpatient lymph node biopsy, and he was sent to the ED because when they found out his platelets were less than 10,000, they got scared. All right, so what do we think this guy has? Yeah, he's got cancer, specifically lymphoma. And so he had ITP secondary to classical Hodgkin's lymphoma. He got IVIG, steroids, Rituxan, and then 2.5 months in, he eventually got a splenectomy because of how bad his ITP is, and eventually he went to remission. Now, this was a guy that me and my senior went and saw, like, I want to say block 3 of my intern year when we had the hem-onc service. Literally, that was what they called us with. They're like, he was supposed to go to lymph node biopsy, his platelets are less than 10,000. We went down there, his fevers were up to like 38 degrees. He was like he was fever up to 38, he had a respiratory rate in like the 30s. Blood pressure kept dropping. I think I gave this guy a unit of platelets every day for like 24 days straight. And then I went to nights right afterwards. And every day I saw the intern in the morning came in and would give him another unit of platelets. I think this guy used more platelets than I've given blood in my entire lifetime. Like every day his platelets were less than 10,000 and his hemoglobin was less than 7. And he required just an immense amount of transfusions. He could not, like he literally got stuck here for 2.5 months until they finally took out his spleen. And literally the day after they took his spleen, his platelets went from 10,000 to 50,000. And then 2 days later, they're 150,000 and they discharged him. Now, kudos to the surgeon who went in and took out someone's spleen with no platelets. Not something that's easy to do. Who is texting me that much in the morning? No one important. All right. So next case, 84-year-old male, history of prostate cancer, metastatic to bone, comes in. PSA was previously normal, now it's 152. He used to be getting Lupron injections, but they're not really working, and now he's getting progressive thrombocytopenia. That started in August. All of his viral labs are normal. Aspirin and Plavix were discontinued, but his platelets are still going down. They're coming down to 20, 10,000. He's got schistocytes on his blood smear, elevated D-dimer, elevated LDH, PT and PTT are elevated, and he has a low fibrinogen. What do we think this guy has? Yeah, so he has DIC secondary to extensive metastatic prostate cancer. And so what you do is you transfuse him, you give him cryoprecipitate basically every time his fibrinogen comes below 110, and then keep monitoring his levels. This guy definitely expired after he went comfort care because, I mean, his metastatic prostate cancer would not allow for anything to really get done. They treated him with like 3 different chemotherapy regimens in the hospital. The big thing about this is the metastatic prostate cancer, what happens is as the cancer metastasizes and continues to infiltrate into bone marrow, it continually exposed more fibrin split products and more antibody sites. So basically, as his cancer got worse, his DIC got worse. And then as his DIC got worse, it allowed his cancer to kind of infiltrate more. So basically, he had an exponential course of he was feeling fine. His cancer really wasn't that bad. His DIC kept getting worse. His metastasis got worse. And basically, by the time he expired, he just literally had mets to all of his bones everywhere. So basically, they both fed off each other. And so the metastatic prostate cancer literally opened up more split products for DIC. DIC fed on it and opened up more areas for the metastasis to grow. And so he was a very aggressive case, someone who had been very, very controlled on his Lupron injections, and then all of a sudden just spiraled out of control. And basically, it was the cross-linking between these two things. And so this is kind of what you'll see out there. Like you'll see all sorts of crazy cases like this. And they still see them on the MedOnc service. So I'd highly recommend any of you who haven't done the MedOnc service to go out there and see this, because I mean, this area is honestly rich in cases like this that get transferred from all over the region, where you have patients where you kind of have to start putting these things together, and they end up making great case reports. They're great for research. Honestly, it's a really solid service. All right, 4 etiologies to be concerned about. So the top 4 that I usually think about are DIC, heparin-induced thrombocytopenia, ITP, and TTP. So DIC, systemic process causing thrombosis and hemorrhage. It's coagulation of fibrinolysis that become abnormal, where it's activated within the vasculature, leading to ongoing coagulation of fibrinolysis that just keeps going and going and going. For the most part, it's just when blood is exposed to the procoagulants and goes from there. It's commonly associated with gram-negative bacteria because of the super antigens that are associated with their cell walls, but also with trauma, malignancy, hemolysis, pregnancy complications. They very quickly consume clotting factors, especially 5 and 8, which is why a lot of times you're giving them cryoprecipitate to kind of build that back in. It's a clinical and laboratory diagnosis, but there's nothing that really rules it in or rules it out. It's not like there's a test that just says this is DIC. It's very much a clinical diagnosis that you're putting together with your gestalt. And so you kind of have to rule other things out and make sure that this is kind of what the pattern that you're seeing. And so that's kind of the big thing, is you have to have a high clinical suspicion and just kind of keep looking for it. But the kind of patterns I mentioned before with that other case is elevated D-dimer, fibrin split products, D-dimers, prolongation of the PT and PTT, and then low fibrinogen. And kind of how you track it is the platelet counts and the low fibrinogen. So you kind of just keep going with that. Now, the most important thing about this is you treat the underlying disorder. So if they have an infection, you treat the infection. If they have a malignancy, you treat the malignancy. And that's kind of what you do. There's not a whole lot else you can do besides give them platelets, give them cryoprecipitate, and give them fresh frozen plasma if they're bleeding. And honestly, they're also prothrombotic. So if they start clotting off, you kind of are in a big situation of where you have to either decide to heparinize them or not. And so this is actually, once they start clotting as well, you kind of run into a problem. And usually those patients do not do well. And as I mentioned, thrombocytopenia, big risk factor for mortality. All right, so HIT. Heparin's a polyanion. It binds to positively charged platelet factors. It's usually IgG mediated. It usually results in the cross-linking of these antigens and cross-platelets. Now, the big thing is that there are actually 2 different types of HIT. There's type 1 and there's type 2. And type 2 is often confused with the type 1, which is transient, and it's not the serious kind that we worry about where we use the 4 T-scores. So this type 1 is usually much more common, and it happens to about 10 to 20 to 30% of our patients, and it usually only results in a platelet consumption of maybe 30%. And so if you've given someone heparin, their platelets start dropping, but you really don't see any other factors. They can still have HIT. It's just not the serious kind that we have to worry about and start them on our Gatroban for. The serious kind only happens in about 1 to 3% of heparin-exposed patients. And so I think that's a big thing that most people kind of look over, is that HIT type 1 versus type 2 is actually a very important distinction. And that's why the 4 T-scores, which we're all very common and very familiar with, is actually so important, because that kind of tells you when to start treatment, when to test, and when to do both. Once upon a time, the 2 tests they have, I believe it's the serotonin release assay and the, what's the other one? The PF4 antibody. They used to do the 2 tests separately. And one, the screening test, would come back after 7 days. And then the immediate test, the more specific test, would come back, the confirmatory test would come back immediately. So you'd have to wait 6 or 7 days for the send out for the screening test before you could even get the confirmatory test. And so what we started doing was just sending them both together. And I think that's what they do now. But it was just the biggest pain, because it's like, why am I waiting 6 or 7 days before I can send out yet another test? Like, it was just huge. It was a huge pain. Anyways, the functional assays kind of give you the ultimate answer about whether you have type 2 HIT or not. And so that's kind of where you go with that. All right, so ITP. So primary ITP is acquired without an underlying condition. So it's a diagnosis of exclusion. And so it's often associated with other infectious diseases, but I'll get to those. And so differentiating from other causes is very important. So ITB is very important to rule out from, say, DIC, TTP, HUS, all those things. And so it's more just a platelet problem as opposed to you don't really have the schistocytes and anemia that you have in other patients. Let's see, there's really no sensitive or specific test as well. You don't test for antibodies in patients. It's not high yield. It's not useful. It's an expensive test, and it really doesn't give you a good answer. Its mechanism is autoantibodies, as I mentioned, but we don't test for them. Platelet antibodies are demonstrated in 80% of cases. It's often secondary to HIV, lupus, thyroid, CLL, lymphoma, and solid tumors. They generally don't have severe spontaneous bleeding with very low platelet counts. Now, that being said, if they have platelet counts below, I want to say 10,000 and hemoglobin of below 7, then they actually become more high risk for spontaneous bleeding, especially in both the eyes and the brain. And I have a good picture for that later. So diagnosis of exclusion, goals to treat the underlying disorder, and then usually treatment options are corticosteroids, IVIG, splenectomy, and usually when they start thinking about splenectomy, it's after 6 months of the other forms of treatment that really haven't started working. And then finally, thrombopoietin mimetics can work as well. And so that's going to be like your tranexamic acid and stuff like that they kind of give. And that'll help too. But ultimately, usually the cure for refractory ITP is going to be splenectomy. They recover very quickly. All right, so TTP. It's going to be caused by severely reduced activity of the von Willebrand cleaving protease, Adams TS13. Everyone kind of knows that by now. It's characterized by small platelet-rich thrombi that cause your microangiopathic hemolytic anemia, thrombocytopenia. You have your pentative systems, which everyone knows, your hemolytic anemia, thrombocytopenia, neurologic symptoms, fever, renal dysfunction. Only 40% have the full pentad. Usually the triad, 3 of these is going to be enough. Now, the big thing about this is that headache qualifies as neurologic symptoms. And so a lot of times people make that mistake. And so very, very minimal neurologic symptoms actually qualify for that. So it's not as hard to start looking down the TTP train, especially when you have just even minimal amount of neurologic symptoms. Most have the hemolytic anemia, though. That's kind of the more profound one. And then usually renal dysfunction is big. You're going to see schistocytes, which I've provided a nice little picture over here on the right. And this is why I mentioned the peripheral blood smear, because this is something where you actually call the lab or call the hemonc fellow overnight and ask them, is this TTP? Do I have schistocytes? Should I be starting plasmapheresis? And should I be getting a central line access? I feel like this used to be a big thing on nights for us when we had our hemonc service. Like usually once a week, someone would come in, they'd have TTP, and you'd have to get this all started. Now this kind of goes over to the med-onc service, and so we don't see this often. All right, so kind of what's the workup for a lot of these things? And so obviously the most important thing anytime you see abnormalities on a CBC is repeat the CBC. Next would be obtain a peripheral smear, obviously look for infections. After those kind of, low-hanging fruit, go look for your autoimmune conditions. So start with screening tests like ANA and antiphospholipid antibodies. Liver function testing is going to be big. Your coagulation cascade is going to be big. Fibrinogen, LDH, haptoglobin, D-dimer. I think a lot of people don't think of this, but the renal function is also going to be super important. So always look at the kidney function when you're dealing with anemia and schistocytes and thrombocytopenia. And the antibodies are going to be much, much more further down your algorithm. So this is just kind of like when you're shotgunning this and you don't really know what's going on. It's the middle of the night. This is kind of where you can start. And so bleeding versus thrombosis. Thrombocytopenia itself does not protect against thrombosis. And a lot of people make that mistake. It's kind of like in liver failure. They're both more prone to bleeding, but they're also more prone to clotting. And so a lot of times with DIC, with TTP, with antiphospholipid syndrome, even though their platelets are low, they're still much more likely to clot on you than, say, a normal patient who has normal platelets and doesn't have these problems. And so kind of gives you a problem where if they do start clotting, what do you do? And so it's kind of, honestly, a lot of times it's just a clinical judgment of what you think they're going to have more problems with, bleeding or clotting. And then a lot of times you can ask the hemonc fellow if you're really in a bind. So what are treatment options for when you get into this? And so DDAVP is a big one. So it's a synthetic form of arginine vasopressin. It increases plasma levels of von Willebrand factor and factor VIII for a few hours. And so this will kind of give you a little bit of extra stuff. And so someone comes in with, a BUN of 160 and you're worried that their platelets won't work, in order to give them a little bit of an extra boost so they won't bleed out on you when you're placing a VAS cath, DDAVP will kind of give you a little bit of that, so you can kind of avoid them bleeding out when you go through that second dilation on their vein. Corticosteroids are useful. especially when it's ITP. Rogam can be used in Rh-positive patients with ITP and bleeding. It induces splenic sequestration of the Rh-positive antibody-coated RBCs, sparing platelets. That's a little bit more of an advanced thing. I don't think we did that with our guy who had ITP because I think he was Rh negative, but I can't remember. Plasmapheresis can help. Cryoprecipitate is a big thing that'll help, and it usually contains factor VIII, vulnerable event factor, and fibrinogen, and so that's usually pretty helpful. Bleeding patients, all right, emergencies and other hospital considerations. Okay, so this is actually this guy's eye, because they called me at like 6:30 in the morning when I had just showed up. I'd taken over the pager, and they called me. They're like, "Hey, this guy can't see," and I was like, "What do you mean he can't see?" I was just like, we think he's blind," and I was just like, "No, like that can't be real. Like he could see last night when I left. Like this is ridiculous. Why didn't anyone call anyone overnight?" So I go look, and like I could see a little red ring outside of his iris on both sides. And I was like, this seems bad. And so I called the ophthalmologist at like 7 a.m. Of course, of which I got yelled at. And I was just like, "Can you please just come see my patient?" And then I called the hemonc fellow, and I was just like, I don't really know what to do. Like, his hemoglobin's low, his platelets are low, and he tells me he's blind. Hemonc fellow is just like, stat 2 units of platelets right now. I was like, okay. And so the ophthalmologist came in and like brought this little thing out, and this was his retina, and this is just blood like pouring out through his eye. And like, I was just like, well, what do we do for that? And the ophthalmologist was like, nothing. Like, it's done. He's blind for the rest of his life. And I was like, okay, all right, sounds great. I was like, I can handle that. And I was like, all right. And so we explained to the guy, and the patient's like, okay. I mean, he's a very nice guy. That was not the problem. The problem was when his family showed up 4 hours later, and I got that page, and they're like, "Can you come please explain to the patient's family why he's blind?" I was just like, okay, all right, sounds great. I look at my senior, he's like, "Nah, man, this is all you." And I was just like, awesome, great day. I was like, "Is the attending still here?" They're like, "No." They're like, "Is the fellow still here?" I was like, "No." I was like, okay, all right, I'll come talk to him. There's both eyes. Yeah, he's permanently blind. And so what happened is basically these patients with platelets that go less than 10,000 and hemoglobin that goes less than 7, they become much more higher risk for spontaneous bleeding. And for his, it was in the retina. Now, they also can have hemorrhagic strokes from this. And so this is kind of the thing that you'll get called about. And so this is one of those things where if he had started complaining of neuro concerns, then that would have been indicated for a CT head stat to look for hemorrhage. And then in this, it's just call opto immediately and see if there's anything that can be done. Unfortunately, there wasn't, and it wasn't even one of those things where they said if anyone had called sooner that they could have done anything. It's just something where this was just, a side effect of him being just so profoundly thrombocytopenic. But the other things you'll see is you'll need to do massive transfusion protocols. And so you have to remember that platelets are a major part of that. You have to be concerned about major bleeding. You have to be concerned about thrombosis. And so these are kind of things you have to start thinking about, especially when you're out there practicing on your own, whether you're a fellow, whether you're a hospitalist, whether you're an internal medicine doctor out running a clinic. These are just, really big emergencies. And you kind of have to always have like step 1, 2, and 3 in your mind. And so, yeah, this guy was a very interesting case. He's the guy who I sat there and gave platelets to every morning for basically the better part of 2 months during my intern year. He's cancer-free. He left the hospital. He walked out. He was the Hodgkin's lymphoma guy. Yeah, he's 27. I saw him like 2 years later, like walking around the hospital from a follow-up appointment. So he went into remission. He got better. Like he's completely cancer-free, but he's blind. Yeah, I don't think I've ever gotten a page quite like that before. Like I've gotten a page like, "Oh, your patient's coded." I'm like, okay, like, but they're like, "Oh, your patient can't see." I was like, what do you mean he can't see? I was like, I don't understand. They're like, "Will you just come bedside?" I was like, I guess. I was like, what am I gonna do? I'm not an eye doctor. You just call so there's no order for it. You just literally get on the phone, you call the blood bank and say, "I want to initiate master transfusion protocol. Get me a thing of blood up here." It's literally a cooler. You're going to use it. I mean, like if you're initiating it, you're more than likely going to burn through this thing. And I don't think it just comes with blood, right? It comes with like platelets. Yeah, and so I think I've gone through 2 of those once. And usually a lot of times it's like, and so in the ICU, it's usually a variceal bleed where you'll see this. And so someone's coming in, someone's going to put in a Cordis. You're going to call for massive transfusion protocol. They're going to say, "Are you serious?" And you go, "Yeah." They're going to show up, and then the nurses are just going to, they're going to slam just all these units through a Cordis as fast as possible. either VIR or GI tries to fix what's going on. It's kind of cool the first time you get to do it. The second or third time, it's far less cool, and you're just kind of like, okay then. But yeah, so there's no order for it. You just call the blood bank and say, hey, I want to activate massive transfusion protocol. And then usually they make you document in a note. They're like, okay, I want all this blood untyped and unscreened for this patient. And then usually they'll send it up for you. Yeah, this is what makes medicine fun. You get to do interesting, cool things that you wouldn't do anywhere else. All right, so platelet transfusions, they can cause slightly increased risk of thrombosis. And so this is why we have the hemoglobin and platelet guidelines that we do. And so your platelet guideline of 10,000 and your hemoglobin guideline of 7, the reason why they exist beyond just the risk of infection and other things that you get is because you're transient increasing thrombosis risk in these platelets for VTEs or other clotting. And so that's why, like when they did large studies about people who got transfusions of either platelets or blood, they tended to do worse once they were above those limits, and they tended to do better when they were below those limits. And so these are very large studies of where we're getting this information from. It's not something where they just picked a number that looked good. And so usually the big problem is thrombosis. And then I think the only caveat to that, it's 10,000 if the patient's normal. It's 20,000 if they're febrile because they consume more during fevers. Let's see, platelet consumption disorders and platelet function are transfused only for bleeding. Yeah, that's fine. Not held in bleeding, feeling. Oh yeah. So if they're bleeding, even if they have like DI series on that, you still give them platelets because they're bleeding. That's just how it works. Okay, so these are levels to transfuse for common procedures. So neurosurgery, ocular surgery, platelet goal is 100,000. Most major surgeries, so you like your hips and your knees, they're going to be 50,000. Endoscopic procedures, technically studies show you can get away with 20,000. Probably most of our specialists are going to want closer to 50. BAL, 20 to 30, they can get away with. Central line placement is technically 20,000. Probably most people in the hospital, except for an ICU fellow in the ICU, will go less than 20,000. I've definitely seen them do it, but I don't really see anyone else doing it. You guys should not be placing central lines less than 20,000 unless you're in the ICU. Lumbar puncture, it's 10 to 20,000 only if they have a malignancy that keeps them from getting to a normal amount. Otherwise, it's 50,000 or above. Like this is one of those things where, like when they, radiology calls you and says, we're not doing the lumbar puncture, platelets have to be greater than 50,000. And you're like, dude, the guy's got ITP. That's why I'm asking for the lumbar puncture. I need to prove it. He's not going to give up 20,000. I gave him 3 units of platelets today, and he's 16,000. So in the studies for them, the recommendations are 10 to 20,000, but otherwise it's 50,000. Epidurals, it's 80,000, and then bone marrow aspiration, it's 20,000. I guess I don't know how many times you guys have seen this, but I ran into this problem a ton as an intern and as a senior, where like I constantly was battling to get either a lymph node biopsy or a lumbar puncture with someone who had platelets of like 15,000. They never went anywhere, no matter how many platelets I gave them. Anyone else have that experience ever? Okay. It used to be like the bane of my existence, was trying to convince radiology that I gave them 4 units of platelets, burned through all of them, and he still has a platelet count of 10,000. Will you please do a lumbar puncture? They're like, why can't you do it? I was like, because you like literally have an X-ray. You know exactly where to go. If I sit there and stab this guy's his spine, I'm gonna make him bleed. Like what? How does this make any sense? Anyways, all right, main take. So paracentesis, like there really aren't that many guidelines in terms of INR or platelet levels because it's just not a high risk procedure. Like technically, even without using ultrasound, like the complication rate for paracentesis is exceedingly low. And so it's probably in the 10 to 20,000 range, but it's not even on the list from where I got this because it's just not that common of a problem. And so when they give you the INR, blah, 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 like there isn't even, the studies show there isn't an INR guideline for paracentesis either. That's just something that they've made up on their protocols. So paracentesis is, you can get away with far more. The serious ones are lumbar punctures. Like that's actually the most serious one in terms of when you go stabbing someone in the spine, you really need to check those platelets. Let's see. Sepsis and infection with decreased mo are the most likely etiology, especially in the hospital. Repeat abnormal labs over and over and over again until you feel more comfortable. Transfuse higher than 10. NSAIDs and aspirin are relatively weak inhibitors, but they last for the entirety of the lifespan of platelets. Let's see, takeaways part 2. So if they have AMS or headaches, think TTP, HUS for recent GI illness, HIT for thrombosis with heparin, treat the underlying disorder, give platelets to actively bleeding patients, even in DIC or ITP, Serotonin release assay confirms or rejects the diagnosis for HIT. And then if TTP, contact the database in partnership with ECU, UNC, and Duke. That gets us study for this. All right, what questions do we have? Sure thing.
But you know, one thing that we found was that and then what she had for vitamin B12 deficiency causes cystitis as well. It's a rare cause, but it can.
So what was her vitamin B12 level with that?
I think it was around less than.
Okay, that's cool. Yeah, and so I mean, like, so technically, vitamin B12 is also a method in which you could get thrombocytopenia, but you know, schistocytes in and of themselves do not, you know, confirm TTP. It's just, yeah, obviously they come with a lot of different things, and so whenever you see cysticytes, your ears should definitely be perked up, but at the same time, like, that's why we go through all these algorithms. That's why we go through the entire clinical presentation. But that's actually a really cool case. Did you guys write that up?
Yeah.
Very cool. All right. Yeah, please do. I'd actually really like to see that. Any other questions from anyone? Awesome.